Okay. Well, everyone, welcome to the last lecture for Intro to Movement Neuroscience. I hope that you all enjoyed the course. I am sad to see you all move on, but I am very proud of all of you. Loved the interaction that we had for the semester, and I hope that this course would be interesting and also motivating for you all to carry on in your studies. I hope that you can take a lot from it, not only from just specifically the material, but I want you all to give yourself a pat on the back with consent because you were able to take a course that has a lot of material. It's really in depth and able to handle it really well. So congratulations to all of you. That's awesome, Justin. Which is crazy to think that the heart, well, people say, like, I think that neurology or neuroscience gets a bias of being very, very difficult. But for the most difficult class to be the most exciting or your favorite says a lot about you and your interest in the material and hopefully the course delivery as well. Yeah, I think so. I do the motor control and neuroscience courses, but sometimes I fill in for other courses. Thanks, Joseph. And I gotta be honest with all of you, it helps having the feedback from everyone or the interaction because it sort of lets us guide the lecture to kind of figure out where everyone's head is at, and then we can kind of like work with it, you know? I feel like, oh, this I'm being recorded right now, but I feel like some professors don't like being challenged, maybe. And so I think the first thing as a professor to do is sort of put aside your pride and sort of run through the question with the student, because then you get an understanding of how to best answer the question in a way that they understand, right? I don't think so. Maybe. So the, like, because I have my business and the clinical stuff I like the best. I love teaching just for the interaction with the students. The one thing with having practicing so much is that it's hard on my body, but for the time being, I could maybe just run clinics, right? Sort of oversee them and then go full-time teaching. With a full-time teaching situation, I would have to be doing research. I'm currently doing research right now. I'm working on ethics for our neuroscience projects, but you all can enlist if you're interested. So to answer your question, Joseph, maybe in the future, like once I get sort of the business stuff sort of figured out better. Yeah, I kind of have a 5-year plan, I guess. Because I'm very busy. Like I feel like I don't. My con of myself is like a work-life balance. I'm sort of like heavily into work. I've always been that way, so I feel like I could probably work on that for myself. Any questions before we get started? So I will be doing a post about the breakdown of the final exam. It's not cumulative. It'll be modules 7 to 9, 7, 8, 9. And it'll be the same format, multiple choice and short answers. It's just 65 multiple choice and 20 marks short answer, I think, or 25. No, I haven't done any practice questions. I think there is a review out there. It is 120 minutes, yeah. So you get more time for a little bit more questions. In terms of the short answer questions, I think that you'll be able to pick out really quickly which ones are the ones that you would want to study for. things we discussed a lot about. Yep, April 19th at 3:30. And again, the delivery is online. Everyone's okay with that? Perfect. So with today's lecture, we're finally sort of wrapping up everything and now talking about the spinal cord. I reviewed the anatomy of the spinal cord in the asynchronous lecture. And it's interesting that that's basically the first thing we talked about, right? So it kind of comes full circle. And then what we're going to finish off with today is talking about the connections or the interneuron connections in the spinal cord that allow for coordinated movement. So originally, we used to think of the spinal cord as just like a conduit from, brain to body. But now we understand that the connections within the spinal cord are so important for our ability to do lots of things. But the point of this course is movement. So as I go through these slides, was there any questions about any of this material? Things that you may have found interesting. Ooh, okay. So look at this slide. See how isn't it interesting that we've talked about all these tracks? So before, when you first started this course and we looked at this and you were like, whoa, now we know what they all do and how they contribute to movement, right? Super interesting. So these are the spinocerebellar tracks. Look how big they are. Right here we have our spinal thalamic tracts. Here we have our dorsal column. Look at the biggest tract is our lateral corticospinal. And you see on the slide how it says SLTC, SLLTUTC. That means cervical, thoracic, lumbar, sacral. Cervical, thoracic, lumbar, sacral. Cervical, upper thoracic, lower thoracic, lumbar, sacral. And so if you look at the slide, it even shows how much organized or organizations there is in terms of like the wires going in and out of the spinal cord. Yeah, sometimes they're in the middle. It's the way that they stain them first, to be honest. So like if you look at the dorsal column, but Carl, the reason why they do it, the breakup like this, is because the sensory stuff comes into the dorsal root of the spinal cord, whereas ventral, the motor comes out of the ventral root. So it's not, they didn't label it much based on the location in the white matter. They're talking about the rootlets or the spinal nerves or the roots of the into the spinal nerve that the information is going or coming from. If you look at this one, see how this is another organization here. See how we have like, this is the fibers coming into the dorsal root ganglion, right? So the tracks are going to be lateral and dorsal. The dorsal root ganglion, see these fibers come all the way up. Here we have our unmyelin axon, so you can see how they're coming into the gray matter. Do you get that, Carl? Now, does it make sense with your question? Yeah. And then if you look at the naming, so the reason why they call it the lateral upper motor neuron tracts is because technically it was lateral. The medial upper motor neuron tracts were medial, even though they're kind of anterior. The dorsal column makes sense. It's named because it's the dorsal side. Yeah. Anterolateral system. See the lateral spinal thalamic tract, anterior spinal thalamic tract. That's why they labeled it as such. So this is all of the tracks that we've talked about in the course. So it would be very important for the questions on the final to know this. We talked about this already. Any questions about any of this stuff? No questions? Perfect. So now let's talk about the function of the spinal cord as it pertains to motor coordination, right? Like I said earlier in the lecture, that we used to think of the spinal cord as a simple conduit, but now we understand that because of all of these connections with the interneurons, there's so much modulation and coordination that occurs as a result of the signals coming in and out of the spinal cord, which really all those connections decreases the amount of processing that's required in the cerebral cortex and the rest of the brain structures. And so the majority of that coordination through the spinal cord is as a result of the use of our interneurons. And the term interneuron is just used as a bridging neuron between other neurons. And so we typically have like our sensory and motor neurons and then we would have a bunch of interneurons right in the middle. Now, remember, Joseph, you were asking me about the interneurons? And so the one point that I want to get across for everyone in the class is that, remember, for every one sensory neuron, we have 10 motor neurons, and then we have 100,000 interneurons. That means that because of diverging and converging signals, having all that amount of interneurons in between the sensory and motor side means that information coming in can affect so many different areas. And that's the way the spinal cord is able to coordinate movement. It's sort of a visual I have to get across with all of you, because it's not like there's a brain in the spinal cord that's processing it. It's just connections that after the information comes in, it will turn off this one, that turns off this one, this turns off this one, this one turns off this one, this turns on this one. It's like so many connections. And so having these connections will allow us to have and coordinate, have a goal-oriented or have or modulate our goal-oriented movement. And so through the integration of signals coming from the periphery, ascending and descending signals, then we will get modulation at the spinal cord. And so we look at, we were talking about our lower motor neurons firing. Think of all the interneurons that would be in between, or try to remind yourself of all the interneurons that would be in between at that level. What's determining if a single alpha motor neuron will fire? Up to this, we had our upper motor neuron tracts, and those send out a signal to the lower motor neurons. But that descending signal is integrated with all of the other information coming in from the interneurons, right? That would be probably from afferent information coming in, maybe other descending signals. Then we get summation at the lower motor neuron. And so what determines if a single motor alpha neuron will fire? It's a summation of activity from 20 to 50,000 synapses. So we talked about in the first midterm general summation. We're looking at examples of like 3 synapses. There's actually probably 20 to 50,000 happening at once. And so the integrating all of that information is like the modulation or coordination that is produced through the spinal cord. So because they don't have, like they would be labeled as the 2 connections that are in between. Because they're in between bigger neurons, they would just be labeled as interneurons, and you could label them as an interneuron between this and this, because they're much smaller. But it's through this slide. This is the slide I sent Joseph. Think of it this way. So we have a descending command. So Shane, you want to tell your leg to kick or step, okay? That's a signal getting sent down, right? You want to step, or you want to okay, let's say the goal of what you're thinking about is you want to lean onto one side, okay? You just want to put your body weight onto one leg, okay? So you send that signal down. And we would have upper motor neuron tracts here. Then we would have hypothetically, our 100,000 or 50,000 synapses with the inner neurons right here. And then this is the output to the lower motor neurons. So this slide is to sort of indicate how modulating can lead to coordinated movement in that it would modify the descending command. So we have the same descending command on each side. This is a completely hypothetical situation, but it's just to show or sort of reiterate how interneuron connections can produce movement or help coordinate movement. Same command on each side, right? Here we have this command comes down. It gets, so at the level of where we have the upper motor neuron reaching or synapsing with the lower motor neuron, we have all these interneurons in between. In this case, we have 3 interneurons, okay? Interneuron 1 sends a signal to muscle 1. Interneuron 2 sends a signal to muscle 2. So in this, muscle 2 is the gastroc. And then interneuron 3 sends a signal to muscle 3, which is tibia in this case. Yes, that's exactly it, Hannah. Because like, look at this situation. So in this case, we have one descending command coming down, right? Now we have interneuron 1 synapsing with muscle 1, so lower motor neuron 1. So we get activation of the quad, okay? Here we have interneuron 2, which connects to the gastroc. So it's going to activate the gastroc. But if you look here, this interneuron splits and inhibits interneuron 3. So it's turning off the tibia. So here we have an example of how one signal, because of excitatory and inhibitory interneurons, it's sort of activating these two, but turning this one. It's the connections in here that are modulating the descending command. So it would all be just the way that they are, the neurotransmitters. So the way that it's organized is that way. So you would have the interneuron here already attached to this interneuron, which would inhibit this one, right? And so what would happen hypothetically is this with this situation. And then Sean's right in that, look at this example here. This is how sensory information coming back into the spinal cord will change the normal connections. So here in this case, we have afferent information coming in, right? So we have our, remember, whatever, give me a proprioceptor or some sort of sensory information. We have a sensory information from somewhere coming in the leg. Sure, let's say GTO in the gastroc, right? So that afferent information is going to come in and inhibit, just the way that it's going to come into the spinal cord, synapse, and then an interneuron is going to inhibit this interneuron. So just the presence of a sensory information has now affected this one. So now this turns off this interneuron. So with the same command coming down, you have interneuron 1 firing, so muscle 1 fires. This one is canceled out now, and before it was canceling out this one. So now this 1 and 3 fire. Right? If, okay, so let me show you an example. Hey, Shammy, can you come here for an example? I want to show them like modulation. Okay. Everyone, this is Shammy. She's physio. Hello. Say hello, everybody. Okay, so what I want to show them is like, okay, so what I'm going to get you to do. Okay, you do it to me. You do it because I want to have myself in the face. Sit that way so they can see. Okay. So hold my arm. I'm just gonna like try to flex, right? So I'm telling myself that I want to flex against resistance. So you pull, right? So I'm saying I want to flex. The afferent information from the muscles, from the joint, is putting feedback back into my spinal cord and probably modulating the activity of which I'm activating my muscles, right? So if she lets go, so you can let go fast because I'm flexing, right? So don't tell me when you do it. So yeah. So that was me hitting myself in the face. But it's because of the modulation, all that afferent information is probably turned on the resistance of my biceps muscle because I'm flexing against something. All of a sudden, if that's gone, that modulation was still there. So then I hit myself, but it takes a second before it sort of all just rewires. So the way that works is, thanks, Jamie. So do you see how with the same command coming down, all that afferent information will modify the activation of the different muscles at the level of the spinal cord. So that way my brain doesn't have to figure it out. It's just all happens through interneuron connections. And so that was an example of using 3 interneurons. Now imagine that in reality, it's 100,000. So every little proprioceptive input, all this or sensory input, all pain, temperature, everything coming in, plus everything coming down, is going to have an impact on so many other different interneurons. And so all those connections are constantly adjusting for what the information coming in. Does that make sense? Perfect. So that's the way that the body is able to accomplish so much. Because or else all of that processing would have to happen in the brain. It wouldn't work. So that's why we understand now that the spinal cord, and specifically the fact that it has so many interconnections all throughout it, is able to contribute significantly to coordinated movement. And so, do you all remember the term schema from 2 lectures ago? So what they say is that if you look at an area of the spinal cord, it represents a schema of what's happening to the body because of all of the information coming in from the afferent information, right? So all of the afferent, all of the different types of sensory or receptors, and then therefore the neurons are coming into the spinal cord. It paints a picture of what's happening in terms of afferent information in the body at that time. So at any time, if you look at the spinal cord, you can get a schema or what the body's doing because of everything coming in. It would, paint a picture. Cool. So now let's give you four examples of interneural circuits that would contribute to motor coordination. So the first one we're going to talk about is stepping pattern generators. Now, I'm bringing this one up first because we talked about the stepping pattern generator in the lower back that is contributing to walking. Now, which upper motor neuron tract was responsible for activating our stepping pattern generator? Reticulospinal, yep. And so we have, for a lot of our rhythmic movements, we have stepping pattern generators. So we have pattern generators. For a stepping pattern generator, it is talking about interneural circuits that contribute to the rhythm of walking for humans. And we have it in our lower back because it's our legs. So would a four-legged animal have 2 or 1? Depends on the animal. So it's zoology. Yeah, they would have 2. Depends. So, okay. So if the animal can use their hands, like bears, and then they have that's a level, of course, versus like horses, right? Where they can't eat, like they walk together. Potentially they could have. So in this case, consider we have a stepping pattern generator in our lower back for the rhythmic walking of our legs. And so the way that a stepping pattern generator is just a collection of different neurons that cycle. So it's the point of our stepping pattern generator through the use of interneurons, timed interneurons, are going to reflexively flex extend our hips. So this is a hypothetical example of our stepping pattern generator. Now this is sort of the interneural circuits for one side. So this is one leg. So you can see how we have an upper motor neuron. So this would be our reticulospinal tract. Now it is activating, this is hypothetical, right? This is activating or connected to one lower motor neuron and then a second one right here. So these are 4 different interneurons, and then these are lower motor neurons, 2 muscles for one leg. And so the way that it would work would be the descending command from the reticulospinal tract to say, start walking. It would come down and then send a signal both to 1 and 3, the interneurons. But if you look, interneuron 1 attached to interneuron 2. So when 1 fires, 2 turns off 3. This is time, so after whatever period of time, depending on how fast you want to walk, this one shuts off. And then 3 can activate, and once 3 activates, 4 inhibits 1. So we get a reflexive 1 plus 2 turning off 4. Then 3, 4 turning off 1. And what that would do, depending on how fast we're, right, the rhythm of walking, we would reflexively activate the extensor, flexor of the hip. Now this is a hypothetical question. Like it's way more complicated than that, but it's through timed interneurons that we get the reflexive flexion extension for each side. Does that make sense, everyone? So then if you look at a version up of how difficult it would be, or like how much more connections there would be. So think of now the input of afferent information affecting the stepping pattern generator. So when you walk and you slip on one leg, even do you, like when you're running on uneven ground, are you consciously thinking about the level of the ground? It all kind of just happens, right? The weight in your hips just kind of adjusts. And you're really just, if you're consciously thinking of anything, you're thinking of your hips. I mean, you're thinking of your calves. Because of the stepping pattern generator and the input of all of our sensory organs, so all the afferent information, that's going to modulate those interneurons, which is alternatively going to contract the muscles in a stronger or lesser way according to what we're walking on. So this stepping pattern generator is integrating the exact position of every limb, the status of the muscle contractions, and the relationship of the limb to the environment because of afferent information coming in. So it's not like a brain calculating it per se, like our cortex, but think about how much coordination is happening just from those interneural connections. It's crazy. Do we all get the idea of stepping pattern generators? Because this is a great, oh yeah, all unconscious. I'm sure that some of the information, so for something, Hannah, let me question you. For something to be conscious, what has to happen? Like for us to be aware of something, where does it have to end up? Right, what's part specifically? Oh, I guess you'd be conscious activation too. Yeah, but I was thinking of, I thought you were talking about sensory information, Hannah. But if it ends up in the somatosensory cortex, then we consciously perceive it. If it doesn't touch there, then our body isn't. We're not aware of it, but our body is utilizing it. So all this, yes, would all be. And so the take-home point of so the midbrain is unconsciously sending signals via the reticulospinal activated. Well, because if you consciously told yourself to walk, then you're consciously telling the reticulospinal tract turn on, and then unconsciously all the rest of it's happening. Because the start off would be conscious, right? So the conscious activation is I want to walk. The rest all gets sent out. Well, see, so the autopilot's in the lower back, like the body's on autopilot. We've created sent out, and you coming from the continue walking. The rest is on autopilot. Think of our of a plane, and then the body is the plane, and all the animatronics and all the autopilot, all the different like machinery. That's all happening. We control it, and the rest we guide it, and then all of the different processing handles it for us. So the conscious would be the driver. Rest is the autopilot. Then here's another example of how in this. So part of the stepping pattern generator is that that proprioceptive information that you're talking about, Joseph, coming in, it can have different effects based on the cycle of gait. In stance phase, you want tension because you're standing, right? So the tension, the amount of tension would feed back to positively activate the muscles more to stand. Whereas in swing phase, that same proprioceptive information would be inhibitory. You don't want any tension. So that's also what the stepping pattern generator does, is that it's a rhythmic contraction of our muscles, but it also affects how the proprioceptive information, what influence it will have. And it's all through just different connections. This will inhibit this, that inhibits that excites this, which inhibits that. Does that make sense, everyone? So the point of this slide is to state that what we've been talking about thus far, the last thing to consider is that all of that afferent information that would adjust or modulate can have an effect based on the stance of or the phase of gait we're in. And I don't know if I've shown you guys this. Did I show you all the Locomat machine? You can look on it where they have the patients walking on a treadmill. Yeah, I guess so. Okay. Yep. And so that's why it's so important with the Locomat machine, where they had the gentleman suspended, taking some weight, because taking the weight is going to get all of the proprioceptive neuron, right? So the spinal cord lesion, this person had a spine injury. And so all of the information coming down still works, but then it's broken, right? Then the information coming up is still there, but it's broken. So having the information coming up plus the information coming down helps trying to get those connections to reconnect, to heal. Because so much of walking is and adjusting or regulating or modulating the spinal cord to change the activation of our stepping pattern generator, but ultimately the activation of the muscles in the lower body. So by having the Locomat machine where they're suspended, they have those neurons firing and they're consciously trying to walk. That information is coming down. And so the way to really heal a neural injury is trying to get connections back. And the best way to do that is through trying to get connections going again. This study here, what they did was they found that if they took an electric sensor and activated part of the lower back, they could get the rhythmic contraction of much like walking. So what they did was they used an electrode to stimulate the stepping pattern generator, and when they did that, right, it's like they're mimicking the descending command, and then reflexively the stepping pattern generator just started activating the muscles reflexively, like in a walking cycle. There's also this story of Mike the Headless Chicken. I'm sure there's a video online if you want to Google it. But this was a chicken that it was a farmer, and when they went to slaughter the chicken, it was actually the wife that was cooking the chicken for dinner. She missed or hit the wrong spot and left a lot of the brain stem. And so the chicken stayed alive for 18 months. And so they would feed it with like a little dropper, but it would walk around aimlessly. Sleep. Yeah. Everyone understand that? Not too confusing? Why is it too overwhelming? Or are you just in general? Okay. Sounds good, everyone. Okay. So that was one example. We're gonna go through 4. So this is the second one. The withdrawal cross-extension reflex, we've already talked about, right? Does anyone remember what it was, what it was used for? Yeah. Yep. Exactly. So now we can understand that activation is contributing or happens because of the contribution of interneurons. Okay, so we have a painful stimulus. In this, he is stepping, or they are stepping on a tack. So that would be our painful stimulus, right? So painful stimulus is going to be sent up into the spinal cord. It is going to activate, through the use of interneurons, our flexor muscles of that limb and inhibit the extensor muscles of that limb. And so we get a withdrawal of that limb from the painful stimulus. When it happens in the legs, we also at the same time, because of interneuron connections, we get a contralateral cross-extension reflex. We pull away from pain on the painful side and then extend so that we don't fall with the opposite leg. That's why it's called a cross-extension reflex, and it involves the contralateral activation of the extensor muscles and inhibition of the flexor muscles. And that's all regulated through interneurons. One signal coming in through interneurons gets diverged to different areas and results in the withdrawal cross-extension reflex. Does that make sense, everyone? Who mentioned reciprocal inhibition? I think it was... Who did it? Hannah, was it you? So here we have Hannah's example of reciprocal inhibition. So here's another modulation or coordination of movement through the use of interneurons, okay? So when we flex our muscles, we would have to reflexively turn off the antagonist muscles, or we would get a monosynaptic reflex, right? If the muscles lengthen too quickly, the monosynaptic reflex, or like the tendon tap reflex. The muscles contract, right? So in theory, then if anytime I went to move, if I flexed an agonist muscle, the antagonist would stretch and then fight back. So reciprocal inhibition is a way that when we agonist muscle, we reflexively inhibit the antagonist. So in this case, we're looking at the quad being activated, and that is turning off at the same time the antagonist in this case, which is the hamstring. And that would be accomplished through an interneuron. So we've taught about reciprocal inhibition, but now we understand that it's through the use of these interneurons. So it's not the brain coordinating it. For fine muscles of the hands and face, anything that we're doing fine control, when we do something very accurately, what happens to the speed of our movement? Slows, right? Having slow motion allows for better accuracy. Here's an example of how we do that neurologically. So it's called recurrent inhibition. And in this case here, we're looking at the thumb muscles, right? Fine control. Activating the muscle recurrently also turns on an inhibitory neuron that inhibits the same muscle. So it's like a little bit of a braking system. Kind of buffers our signal to slow it down a little bit so that we have better fine control. Does that make sense, everyone? It's a little bit movement. So because you could, with the descending command, you could just alter it. It's just a baseline activation there, and you would just have to work through it, like through just experience, through repetition. You would be able to, like the amount of information coming down would be enough to surpass the inhibitory effect of the recurrent inhibition reflex. So it happens for fine control, but it's just there as a generalized braking system. Yeah. So it's just there as like a safety check, but we can still go through it, right? You would still be able to utilize it. It's just there as like a little bit of a mechanism to ensure that we're going slower. Yeah, like you would just, because you could still move your hands, right? Think like you still move your hands. But because fine control, there's a little bit of a reflex there, just to slow it down a little bit, just to make sure that it is smooth. Yep. Yep. Anything fine control. Anything when we use fine control, we have recurrent inhibition of that muscle, just as a buffering system. Remember, there's also going to be all the afferent information coming in from the tension in the muscles that are going to be either exciting it or inhibitory the same muscle. We have all the descending command, which is going to be exciting or inhibiting it. It's all how everything's processed. It's just one example. Yeah. Yeah. So it makes sense, right? Like, so if you wanted fine control, it would be beneficial to have this little bit of a reflex there as a safety mechanism, just to ensure that if we really wanted to do it, we really want to have to do it. Does that make sense, Joseph? So with your pitching example, it would do it, but there are concentrating and focusing through the recurrent inhibition. And those were our 4 examples of interneurons contributing at the level of the spinal cord to motion. Now I want to talk about spinal cord lesions, which I find is generally the most exciting thing that you guys are going to learn, because it's talking about like why spinal cord patients present with certain symptomology. So now with spinal cord lesions, the big thing to remember is we have looked at the anatomy. So ultimately, if we're going to talk about what would be the typical presentation of someone with a spinal cord injury, we would just look at what is injured and see what tracts are affected, and then we get an idea of what's injured or how that would present. Right? If you have a spinal cord injury, so depending on, it could be a lesion, a tumor, stab wound, gunshot, accident, fracture, whatever, we're going to look at the tissue that is injured. That's going to give us an idea of what symptoms would be probable from that injury. So in spinal cord lesions, the way they talk about it is it can be either affecting segmental function. So if we have an injury of the spinal nerve or the rootlets or one of the roots coming from the spinal cord, then it's only going to affect that level, that segment, right? So if we had, the most common would be like a one, right? Then we're going to have symptoms just at S1 dermatome or S1 myotome. Whereas if we get a injury in the white matter and gray matter, it's going to affect all of the signals that they're either coming up from that area or going down below that area. So that's what's called a vertical, it's affecting vertical tract function. So when we have an injury to the whiter gray matter of the spinal cord, we have a vertical tract lesion. And in a lot of cases, it affects both the spinal nerve and some of the spinal cord. So then it's both segmental and vertical tract dysfunction. So this is the way to sort of understand it. And let's look at examples now. So if we're going to have just a segmental lesion, we're going to have an injury to just the spinal nerve or the roots coming out or in from the spinal cord. If we have a lesion of the dorsal root, the dorsal horn, or the spinal nerve, we're going to have sensory issues in that dermatome. If we have a lesion to the ventral root, the ventral horn, or the spinal nerve, we will have muscle loss or motor function dysfunction within that myotome. Does that make sense, everyone? Because remember, this is going to be an injury at the spinal nerve level, so it's going to affect the spinal nerve distribution, not the peripheral nerve distribution. So if we had, so here we have C4, C5, C6. At every level, at every vertebra, there's a spinal nerve exiting on the left and right side. Okay? Let's say hypothetically, this person has an injury right here. So a common example would be like a cervical disc herniation. We have a disc in between, it's popped out, and that material is putting pressure and therefore injuring the spinal nerve on the right side. Okay, so what would we believe would be the symptomology or the clinical symptoms of an injury to the C5 spinal nerve? Yep. What else? Yep. Hannah's right, yeah. Because if you look at right here, it's affecting both sensory and motor, but just to that level, right? So that would be just C5 level. Does that make sense? And we are all comfortable with understanding the difference between peripheral nerve and spinal nerve? Yes, that's right, because they mix, yep. Exactly. Because it's hitting the spinal nerve when it's already like both sensory and motor, we get activation here. No, the rami would be out here. So when the spinal nerve comes out, you get the anterior and posterior rami right here. So so all of our spinal nerves exit and then recombine to create the peripheral nerves. Does that make sense, Carl? So if I was to get an injury, let's say down here on the brachial nerve, it's going to affect sensory and motor wherever that brachial nerve is going. Yes, to the right of that lesion, correct, yes. The reason why the spinal nerves come out and then recombine is because our muscles, they go along the whole, big pieces of our body. So it wouldn't work to have one spinal nerve going to one muscle. They need to come out at every level, recombine into the big nerves to go to the different parts of the body. So what happens then, everyone, if let's say the injury was right here, what would be clinically what would happen? So we have the dorsal root ganglion, or the dorsal root of the C5 level is being injured, right where the cursor is right now. So what would be the... Well, no, so just dorsal root. It would be all sensory because it's coming in through the sensory. I said dorsal root, so that was kind of a trick by accident. The pain and temperature neurons would still come in through the dorsal root. Yep, C5. Remember in the cervical area, it's the level above. Yeah. Okay, so then what happens if we had a lesion here? What would be injured, or what would be the symptoms? Yep. Exactly. So depending on where the injury is, it's going to tell us whether or not we have sensory or motor or both to a specific area. Yep. So then if you had it to the right here, like Carl was saying, it would be affecting specific peripheral nerves. The rami are right here. So this is what Joseph was talking about. The spinal nerve separates into the anterior and posterior rami. The anterior rami of all of the spinal nerves recombine to create our plexi, which is then peripheral nerves. So now let's talk about what happens if we have a vertical tract lesion. That's if we get an injury into the spinal cord. We're going to affect ascending. So all the information coming up can't get past the injury. Yeah, C5, yeah. Great. For it to affect C6, it has to be this one. Like this is affecting C5, so it has to be C5. Good. Yeah, no, I think the reason why they said C5 or C6 is because if you had like a C5, C6 disc herniation, what does that affect? No, C5. If it is an L5S1, then it's S1 because of this slide. Right here. See how the spinal nerves exit above in the cervical? Then we have a C8, and then it's below. Yeah. Yep. Exactly. Good job, everyone. So if you had a C7T1 disc hernia, that never happens, but if you did, what nerve root would it be? Yeah. so when we get a vertical tract lesion, if it's affecting the sensory components, so sensory tracts, we're going to get a specific type of sensory loss. If it's affecting a descending tract or a motor tract, we're going to get a specific type of motor dysfunction. And it can also affect the autonomic nerves that would be coming, so it can affect the regulation processes as well. Okay, so here we have a hypothetical example. So here we have our C5 level again. Here, this is the gray, we have a injury that's caused a breakdown or an injury to the whole right half of the spinal cord at the C5 level. What would be the physical signs of that injury? Possible sensory issues from that point downwards. Yeah. Yeah, it would be everything below. So we would have any information, yeah. So any sensory information that's coming up from below C5 is gone. What side of the body? Yeah, that's what you meant, for sure. But what side of the body? Ooh, it's both. So it depends, right? Because let's say the injury's right here, okay? The dorsal column coming up from this side, is that coming from the left or right part of the body? Right. So then, because the cross happens up here. So on the right half, we're going to lose fine touch, proprioception, and vibration, the dorsal column. On this side, we have, remember, our pain neurons and temperature, they cross right away and then come up. So the spinal thalamic tract from this side is what part of the body, left or right? So in this case, we would have loss of fine touch, proprioception, and vibration from the right part of the body, and pain and temperature from the other side of the body. And then motor, what would we have motor loss? Everything below. And it would be on, yeah, on that side of the body. Yeah. Right, yeah. Yeah, I would say facing away from us. So you would lose motor on the right. So the motor crosses over around the medulla, right? So it would already cross over and then get sent down to the right side of the body from the left side of the brain. No, it doesn't really matter. Which part? So if we look at the sensory issues, with a C5 lesion from this right half of the spinal cord, we are going to have loss of fine touch and proprioception and vibration from the right side of the body, pain and temperature from the left side of the body, and have an inability for motor on the right side of the body below the level of that lesion. Below the level of the lesion. So if it was the lower back, you could still move your right arm. It would be the right leg. Because you just think of everything as wires, right? You're just breaking some of the wires that would go to us. So whatever those are going to is now lost. Yeah, I was picturing it going that way, but you're right. Yeah, that one is the hemisection. So clinically, that is called a hemisection. Half cross section is gone. Before, they used to call it Brown Secord syndrome. Before they realized what was going on in the spinal, before they had imaging and stuff. So these were probably the people that figured it out. The old-timey docs that figured it out. because it was probably weird that all of a sudden they have this neck injury. Now people can't feel pain on one side of the body, but they can't feel fine touch on the other side of the body. They were probably like, what? And so Shane's asking a question. If you look at this, because in this injury, see how it took out the nerve roots? So they're saying they also get a segmental lesion of the C5 because that's all broken down. Yeah. Yeah, so in this case, they would say you need some bloodletting and pray, and you will be healed. And take cocaine or opium or something. Yeah, for sure, sacrifice. How many times did that stuff not work where they were like, oh, let's do it again? Like, you know the saying, the hair of the dog that bit you? That comes from if you got bit by a dog with rabies, they thought that if you bit that dog, then you would be cured. How many times did that? Yeah. How many times did that go down where it didn't cure them? Did they realize it's probably not gonna work? I don't know. I'm on an old timey doc. I don't know. So based on understanding the location of the injury in the spinal cord, we get these different sort of like syndromes, but we can understand them when we look at where and what would be affected at the spinal cord level. So here we have an example of anterior cord syndrome. What do you think anterior cord syndrome is going to affect? So here we have a mass, and it's going to affect everything at the anterior side of the spinal cord. Yeah, because everything except for, in this case, the dorsal column is affected. So then if you look at the symptomology, it's affecting everything. Okay, what about central cord syndrome? This happens a lot when there is, like, you know how there's cerebral spinal fluid that drains down the middle? It can get clogged and then cause a swelling. Yep. Does everyone get that? So at the level, so central cord syndrome is where you get a lesion right in the middle. And so as it expands, it'll start interacting with different things. The first thing that it would affect, so even if it was just a little small one, think of the different tracts that we talked about. Which one crosses over at the spinal cord? The spinal thalamic tract, right? So that information comes in, crosses over right away, and then comes up. If we have central cord syndrome, it affects the spinal thalamic tract, or pain and temperature, at that level. So if we had central cord syndrome at C4, C5, that's why they're showing in the diagram we have loss of pain and temperature here. So that's why if you looked at that neurological assessment last day, like the hypothetical one, if someone comes in and through the history that you're realizing there's like a neural symptoms, you just map out their loss. And it gives you an idea of what potentially could be going on. No, because, Hannah, see how it's just affecting, it's in the middle, right? So it's affecting anything that would be just crossing over at that level. Pain and temperature from the rest of the body is already coming up through the spinal thalamic tract. Yeah. Yep. Well, again, depending on how big, maybe it gets super big and it starts affecting like multiple levels. So eventually, yes, it's segmental right now, but eventually, if it gets big enough, it's gonna start hitting vertical tracts, and then it would be a vertical lesion. Yeah, it can be both. Yeah, that's what I'm saying. Yeah, it just depends on what's causing it. Sometimes it's a tumor, then that's really scary. But sometimes it's clogged, and so they if you unclog it with any of the spinal cord injuries, you need to remove what's causing it. Yeah. Here we have our hemisection again. So now it's called Brown-Sequard syndrome. So in this case, we have a hemisection at the right T10. Or do you want to say it's left? No, you just hang them upside down and shake them. No, you need negative pressure. So I don't know how you would do that if you have any ideas. So what about this injury? What's this going to give us? So see how this is a hemisection again, but instead of the neck, it's now lower. So tell me, or is this going to be the right side or the left side? Is he looking towards us or away from us? Okay, so we'll say this is the left T10. Okay. So then what are going to be the clinical signs of this injury? So we said this is the left. So if we imagine this person looking at us, so this would be the left leg, right leg. So ipsilateral process on the left. Yep. Below which level? Yep. Left side motor loss, left side dorsal column, right side pain and temperature. Yep. Have you ever heard the sidebar? Have you ever heard the saying like 3, 4, 5, keep the diaphragm alive? That's the innervation of so that's the phrenic nerve that keeps your diaphragm going. So if you have an injury at the level of C 3, 4, 5, you can't breathe for yourself. So then that individual will be on a respirator forever. The last one is Cotta-Equina syndrome. Has anyone ever heard of Cotta-Equina syndrome or how it relates to disc herniations? I did not make it up. Cotta-Equina syndrome, this one. So Cotta-Equina syndrome, yeah, that's okay. Cotta-Equina syndrome is when you get a lesion at the level of the cauda equina, right? So past the filum terminale. There is a chance that it can start affecting the neurons that are for autonomic regulation of bowel and bladder, just based on the location of it, right? So because it's not one full cord, a mass can kind of come in and start affecting all random stuff. If it affects bowel and bladder stuff, that's a medical emergency because your colon can rupture. If your colon ruptures, if you can't go poo, your colon ruptures, then you can go septic very quickly. Yeah. Yeah. So when someone comes in with a disc herniation, you ask them about bowel and bladder symptoms and whether or not they have numbness over their S1, S2 dermatome, which is like right there. Because it's a medical emergency for this potential of a ruptured bowel and bladder. Yeah, exactly. It's a big concern for physical therapists because people presenting, well, I think they won't really think of it as an emergency for that. They'll be more concerned about the shooting pain down their legs or down their one leg based on the herniation. And they'll think that, oh, I'm having bowel and bladder issues because it's so painful. It's happening neurologically. I think I've only had 3 in my 10 years of practice. Cotter-Quine syndrome. Yeah. And so the patient's more concerned about their pain, but yeah. And everyone, that was the course. So like I promised, we would get a way better idea of all of these things. And now you're all experts. It's okay. No, that would be pretty funny. For the short answer, what I want you to do is I want you to write as much as you can from all of the lectures in 5 pages. You have 3 hours, go. I should have done that for April Fools. No, not long essay, actually. How does neuroscience make you feel for 100% of the final grade? Yes. And you have to handwrite it. Only feelings. And it has to be written in 3rd person as well. From this? Yeah, it's true. Yeah, you're right. Ah. Any questions, anyone? Stop presenting here. Well, it was all a pleasure to have you. It was a pleasure to have you all in the course. I thoroughly enjoyed it. I hope that I get to see you all again in the future. I'll do a posting about my research once I get my ethics approval. Feel free to join up on that one. I don't know. All the best.
Thanks, sir. Bye.
Bye. Okay. Bye, everyone. I'll do a posting about the final exam.